Hello, everybody. Welcome to the top 20 studies of 2025. It's so great to be able to join you today. I'm Jeff Donovan. This is an annual event that we hold every year, which really celebrates some of the top research studies of the year gone by. And it's really my honor to be able to join you today. This webinar will be recorded and posted to our Donovan Medical YouTube channel. And this will probably be posted in the next few days. The webinar will probably last anywhere from 2 to 3 hours. It depends on a number of factors, including how much I elaborate on each case, how many questions we get at the end. There is a question and answer box on the Zoom platform, which I would invite you to ask questions should you be interested to ask questions, and we will address them at the end of the webinar. There's usually quite a few good questions that come in throughout the webinar, and we will save the questions for the end. The outline is shown here. We have 20 really wonderful studies, and these are studies that really change the field of hair loss dramatically. These are studies that change what I say to patients when I'm in the clinic. These are studies that really change how I think about hair loss. And it's really my honor to be able to share these studies with you and review them. And congratulations to these authors. And thank you to everyone who's joined this evening, this morning. I know for some it's the middle of the night, for some it's the morning, for some it's all over the world. And I really do appreciate your interest. We've been doing these annual events for quite some time, and they really are wonderful in terms of the ability to really set some time aside for studies that really make a huge impact. So we'll be reviewing 8 studies in androgenetic alopecia, male and female hair loss, including studies in minoxidil, finasteride, dutasteride. We'll be taking a look at studies in alopecia areata, 4 of them. Studies in the ever-popular GLP-1 receptor agonists, semaglutide, liraglutide, tirzepatide, the Ozempic, Mounjaro of the world. We'll take a look at some hair loss from these drugs. We'll take a look at seborrheic dermatitis and some fascinating studies looking at comorbidities with seborrheic dermatitis. And then we'll focus on scarring alopecia. And we'll look at 6 really wonderful studies that change how I think about scarring alopecia. We'll take a look at a study of lichen planopilaris, looking at low-dose and high-dose doxycycline. Some wonderful studies of FFA, looking at topical JAK inhibitors, as well as a wonderful study looking at just how much affluence or wealth makes a difference in FFA. Fascinating study. Then we'll take a look at the study in central centrifugal cicatricial alopecia, looking at insulin resistance, and then focus our attention on folliculitis decalvans and whether we can transplant folliculitis decalvans or not. How good does it work? And we'll conclude with a fascinating study of dissecting cellulitis. So that's what we have cut out for us. This webinar is recorded. I invite you to stay as long as you can. Leave, come, all is good. I really appreciate the great interest that's here. Let's start with minoxidil. Let's start with androgenetic alopecia studies. And as I review these studies with you, I'm going to begin by telling you some key points about what the study's about. I'm going to summarize it for you in one breath. And then I'm going to give you a little background to the topic. And then I'm going to review the study. And then I'm going to give you some conclusions and just why this study is so important. So that's how we'll approach each of these studies. So let's begin by talking about androgenetic alopecia. Androgenetic alopecia is male and female balding. And it looks different in men and women. In men, it starts with hair loss in the temples, as well as hair loss in the crown or the back. And then over time, those areas fuse together and you can get hair loss throughout the top of the scalp. In women, it looks different. There's hair loss in the middle of the scalp. And so these are both called androgenetic alopecia, and the same thing is happening. The hair follicles are getting skinnier, but they look different in men and women. Let's take a look at the first study, looking at oral minoxidil dosing. Just a wonderful study by my colleagues in Brazil, looking at comparisons of 2.5 and 5 milligrams. And I really love this study. This study showed that 2.5 milligrams and 5 milligrams were equivalent, at least over this 6-month study, 24 weeks. And that's really important because we have a view in our hair loss community that more is better. Do 5, start 5, start all men on 5. And what this study teaches us is 2.5 is pretty much as good as 5, at least over 24 weeks. And so it really changes our pressure to give 5, give 5, give 5. If you don't give 5, you're missing out. You're missing out on all this hair growth. It's really not what this beautiful study shows. This study also showed that 5 milligram dosing causes more side effects, and specifically swelling in the feet and dizziness. So let's take a look at this study. So we've had a debate for quite some time as to the starting dose of oral minoxidil, whether 2.5 is how we should start or whether 5 milligrams is how we should start. And there have been some studies showing that if you go higher, it seems to work better. But these really haven't been well-designed, well-controlled studies that have offered these conclusions. They've largely been observational studies. And this study here by Fonseca and colleagues seeks to address that gap. And so the purpose of this study was to evaluate and compare 2.5 milligrams and 5 milligrams in the treatment of androgenetic alopecia. And so it was a double-blind, randomized trial, and those are some of the highest quality studies. And so when we do hair loss research, there's many ways we can design studies. We can pull all our charts out of the filing cabinet and look back at how people did. Those are called retrospective studies. Or we can design a study from the get-go, from day one, design it right, put people in different groups, and follow what happens. Those are the highest quality studies. Those give us the most reliable evidence. And so this was a randomized controlled trial. These were men aged 25 to 55 with balding. And they were randomized to either getting 2.5 milligrams or getting 5 milligrams. Once daily for 24 weeks. Most hair loss studies are 24 weeks, 6 months. The primary endpoint that the researchers wanted to look at was, what is the change in big hairs at the end of the study? We call those non-vellus hairs. But they also looked at total hair density. They also looked at photographs. They looked at how good patients feel they did, how good clinicians felt the patients did. These were the secondary endpoints. And of course, they looked at adverse events. So who's in the study? 100 people. 50 receiving 2.5 and 50 receiving 5. In all studies, some people drop out, some people can't attend, some people don't want to attend anymore. And in this study, 92 ended up completing the study, which is pretty good continuation. The mean age of patients was 39.5 years, and they had a mix of skin types. Here's the key. There's no difference in the primary endpoints between those receiving 2.5 milligrams and those receiving 5 milligrams. If you got 5 milligrams, you grew just as much hair as 2.5 milligrams over 24 weeks. When dermatologists looked at the patients, they felt, I can't tell the difference between those in the 2.5 and 5. They look the same. Patients felt that they did a little better in the 5 milligram group. So when patients were asked to rate, how well do you think you did? Patients in the 5 milligram group as a whole said, I think I'm doing pretty good. A little more likely than the 2.5 milligram group. So that's important. These patient-reported outcomes are relevant in these studies. And there were more side effects in the 5 milligram groups. The 5 milligram group had more swelling in the feet and more dizziness. And cardiovascular parameters like blood pressure and heart rate were the same. And so really a wonderful study which shows us that when you look at hair counts, 5 milligram doesn't seem to be better than 2.5. They're pretty similar. Now, patients did rate their outcomes better in the 5 milligram group, but just slightly. And so it certainly opens the door to further studies that might be longer term, beyond 24 weeks. But certainly it's a really important study which shows us that 2.5 milligrams is a pretty good starting dose. And patients are not losing out by not going up to 5 milligrams. And in fact, going up to 5 milligrams doesn't seem to offer all that much more benefit, but comes with more side effects. And so this is really the first randomized blind study comparing these doses of oral minoxidil. The prior studies have been retrospective or observational. And so this is a really important study. This really offers us some pretty high quality evidence. And it really gives us confidence that starting 2.5 milligrams in males, pretty reasonable, that not all patients are going to get anything different by going up to 5 milligrams. More studies are needed, longer term studies are needed, of course, but I think this is really important data, which sets a precedence that, the starting dose of oral minoxidil may in fact not be 5, which is sort of becoming ingrained in our literature that you start 5. Males start 5. That in fact, maybe 2.5 might be a very reasonable starting dose. So congratulations to these authors. I think this is a really important study. And this group from Brazil really are some of the leading experts in these randomized trials in minoxidil and really have helped the world so much in understanding with high quality data the efficacy of minoxidil in treating hair loss. So thank you to these authors. The second study is a fascinating study in minoxidil shedding, which teaches us what we have thought we knew, but really provides convincing data that what we have been telling patients is in fact correct. And what we have been telling patients is that when you start minoxidil, you're probably going to shed. And the dread shed can be terrifying. And it lasts 2 months. And we tell patients that if you get a dread shed, it probably means the minoxidil is going to work. This study says that's right, that information is correct, that all this counseling that we give patients is in fact backed up by some good science. So a really nice study in the Journal of Dermatologic Treatment. The key point in this study was that minoxidil 2% and 5% cause shedding. And it starts around week 4. And the more shedding a patient has, the more likely they are to get good outcomes. Pretty important data. A very common reason for emails and phone calls to the office is someone starting minoxidil saying, "Do you really want me to use this stuff? I'm shedding everywhere. If I keep going with this, I'm going to have no hair. There's hair in my sink, there's hair in my bathtub, there's hair everywhere. There's hair everywhere. There's hair in my refrigerator. Are you sure you want me to do this?" This study reminds us, yes, this is expected. And in fact, more shedding probably means you're going to do even better. So minoxidil often causes shedding. It's called the dread shed because patients dread it. Patients are terrified of starting minoxidil because of this dread shed. And in fact, most treatments for hair loss cause some degree of shedding, but it's quite well known and characterized for minoxidil. And this study seeks to really better characterize the shedding that happens after starting minoxidil. And so the purpose of this study was to determine the timing of the shedding after minoxidil and to confirm whether or not high shedding correlates with good outcomes. is high shedding good or is high shedding bad? So it was a retrospective study of 49 patients, 39 males, 10 females, and 2% and 5% minoxidil were studied. 29 patients received 2%, 20 patients received 5%, and the duration was 24 weeks. And patients were receiving twice daily. And so they monitored a number of parameters to follow shedding. Patients' perceptions of shedding, their hair growth by photography, the improvements in density they had, as well as trichoscopic findings. And an important parameter that they followed in this study was the MRAHS, or a measure of relative shedding that patients had. Patients were fairly young. The average age was 25 to 30. The patients in the 2% group and the 5% group were pretty similar in baseline characteristics. Shedding really started around 4 weeks and tended to resolve by week 12. Shedding resolved the soonest with 5% and was a little slower to resolve with 2%. But by week 16 to 24, shedding actually dropped below what it originally was in both of these groups. And so a nice reminder that shedding usually stops by month 2 in those of using 5%, but it can be delayed in some patients, especially those receiving 2%. Is shedding a good thing? This study suggests, yes, it sure is. That the more shedding that a patient had, the more density they achieved in the end. And that was true for both the 2% and the 5% minoxidil users. And so if you shed a lot, it means that if you can stick with it, if you can stick with the emotional aspects of seeing all this hair coming out, you're probably going to do even better than a person who gets less shedding. So really important data, which really reminds us that what we've been telling patients and the counseling that we've been giving is backed up by some pretty good studies. We can all expect shedding. Shedding should improve in 2 months, but in some cases it is delayed. And intense shedding is a sign of a good response coming. And shedding with 5% seems to stop sooner than 2%. And so, very important study in our literature. The only FDA-approved treatment for women is minoxidil. And hair clinicians need to know minoxidil inside and out. They need to know everything about minoxidil. Everything is compared to minoxidil. Minoxidil is such an important standard. And as clinicians, we need to understand minoxidil, minoxidil, minoxidil. And these are some of the fundamental studies in our literature pertaining to here, topical minoxidil. So, powerful study. If you can stick with it, high shedding is not a bad thing at all. So, congratulations to these authors for these important and meticulous studies looking at hair shedding. The third study I'd like to review with you is a very nice study comparing sublingual minoxidil to oral minoxidil. You know, we have a number of feelings in our hair loss community. We have a feeling that high-dose oral minoxidil is best. And we have a feeling that sublingual minoxidil is the best, and oral minoxidil is inferior. And that has carried around the world to many patients saying, you know what, I'm on oral minoxidil, but I want to find a source of sublingual minoxidil because I hear it's the best. This study reminds us that not necessarily the better, just different. And we'll take a look at this study and see that there may be some unique benefits of sublingual minoxidil, including a lower risk of cardiac side effects like palpitations, but in terms of growing hair, not necessarily better. So, a really wonderful study comparing sublingual and oral minoxidil. First author, Sanabria and colleagues. Again, many of these same authors, wonderful authors from Brazil. So the key point of this study, before I dive in deeper, is that in this study, sublingual minoxidil at 5 milligrams was not more effective than 5 milligrams of oral minoxidil over 24 weeks. Palpitations tended to be a little bit less likely in patients using sublingual minoxidil. And we'll take a look at this data in a minute. So oral minoxidil really has become quite popular. And the last 5 years has seen oral minoxidil's use around the world just skyrocket. It's convenient. People can stick with it more. Patients like it. So there's a lot of advantages to oral minoxidil. It can cause hair growth on the face. It can cause fluid retention. And some people can get cardiovascular side effects. Not super common, but a certain percentage can get palpitations. And that seems to be dependent on dose. Sublingual minoxidil has been studied for the last few years as an alternative. When you take a tablet of oral minoxidil, it goes in your stomach, and then it finds its way through what's called first-pass metabolism, and the liver actually helps break down the minoxidil, and you get a surge of minoxidil into the blood, and that can contribute to palpitations, dizziness in some patients. Sublingual minoxidil is different. You put it in your mouth, you put it under your tongue, and it enters the bloodstream and avoids that first-pass metabolism in the liver and provides a much more gentle and controlled way of getting minoxidil into the body. And on account of that, the hope is that the chances of getting cardiovascular side effects are reduced. And so that's been the attractive feature of sublingual minoxidil over the last few years. But there's been a lot of anecdotal information, or in other words, chit-chat. There's been a lot of, I think this, and I think that, and I see this in my 4 patients, and last month I saw 2 patients and they had this happen, and last year I saw 8 patients and this happened. So there's been a lot of anecdotal discussion without a lot of great science backing up the data. And this is a study which tries to provide some good science to back up the data. And so it's a study, a head-to-head comparison between sublingual minoxidil and oral minoxidil in men. Another wonderful randomized trial by these experts in Brazil who do these wonderful, wonderful studies. So the purpose of this study was to compare the efficacy and safety of sublingual minoxidil at 5 milligrams compared to oral minoxidil at 5 milligrams over 24 weeks. A double-blind randomized controlled trial in men with stage 3 to 5 androgenetic hair loss, and they were randomized. Half received sublingual minoxidil, half received oral minoxidil. The primary outcome was a change in total hair density at the vertex, and a variety of secondary outcomes were measured, including changes in non-vellus hair counts and photography, as well as scoring by blinded dermatologists. So it was a study of 110 men. 85 patients completed the study, 43 in the sublingual group, 42 in the oral group. Mean age was 36 years. And a whole bunch of severities were assessed, with half of the patients being stage 3V. So what were the results? Well, total hair density increased in both groups. The total hair density increases were similar in both groups. 24 hairs per centimeter squared in the sublingual group and 21.8 in the oral group, which were not statistically different. The non-vellus hair counts also increased in both groups, not statistically different. And so both had nice results, they just weren't different. Palpitations, however, were different, and patients receiving oral minoxidil were more likely to get palpitations. And it just met the statistical cutoff of p equals 0.05, and about 10% of patients in the oral minoxidil group had palpitations, and there were no patients observed in the sublingual minoxidil group getting palpitations. And hypertrichosis, or excess hair, was common. A lot of people got hypertrichosis. Hypertrichosis, not always a huge concern in men. Some men it can be. certainly is much more of a concern in women. And so the conclusion here is that at least over 24 weeks, 5 milligrams of sublingual minoxidil didn't seem better than 5 milligrams of oral minoxidil. Side effects were greater in the oral minoxidil group, particularly palpitations. And so this is an important study. Sanabria et al. 2025, an important study that teaches us that, efforts to find sources of sublingual minoxidil are not necessarily efforts that translate into more growth. But certainly for patients that have palpitations and patients that have cardiovascular side effects, maybe, just maybe, sublingual minoxidil could have some benefits. By avoiding that first-pass metabolism, it enters the bloodstream differently and may lessen the chances of palpitation. All good studies open the door to more questions, and this study opens the door to more questions. And a common question that I'm asked whenever we talk about oral minoxidil and sublingual minoxidil is, would giving 2.5 milligrams twice a day be associated with less palpitations and equal or better results than 5 milligrams? And so we have a lot of unanswered questions, and certainly the world of oral minoxidil and sublingual minoxidil is by no means finished. These studies are 24-week studies, and an important question is what happens when you're on oral minoxidil for 3 years, 5 years, and 10 years? Do we start seeing important differences between different doses and different types of administration? But at least for now, an important study that tells us at 24 weeks, sublingual minoxidil doesn't seem to offer a hair growth advantage. So congratulations to these authors, and thank you for all the wonderful work that you do in this area. The fourth study in androgenetic alopecia also pertains to minoxidil, systemic dosing of minoxidil, and a really important study which tries to go beyond 24 weeks and looks at hair growth outcomes at 3 years and 5 years. And what's happening in people that are on these drugs for 3 years and 5 years? There's very, very, very few studies in our literature which study patient outcomes this long. And so these are really important studies in our literature. A study in JAAD, Journal of the American Academy of Dermatology. The key point of this study is that patients on oral minoxidil, sublingual minoxidil, can expect improvements beyond 6 months. And in fact, in this study, patients on minoxidil 5 years had better hair density than patients on it 3 years. And so there's improvements that happen over time. And the growth that you get by 1 year is not necessarily the final outcome that you're going to receive. And so this is really important data, which mirrors the kind of data that we see with anti-androgens, for example, where we know that many men on anti-androgens will have further improvement beyond the first year. Let's take a look at this study. Female pattern hair loss is progressive without treatment. It may be slow in some, it may be faster in others. Topical treatments are challenging. Not everyone likes to apply topical minoxidil, and there's a concern in some patients that maybe there is a plateauing of effects after certain periods of time. And so there's been increasing attention on systemic forms of minoxidil, both sublingual and oral minoxidil. The data on long-term outcomes are lacking. And so this was a retrospective study to evaluate how good are outcomes after 3 years, 4 years, and 5 years in patients with female pattern hair loss receiving sublingual minoxidil. So it was a retrospective review of 51 women who were on sublingual minoxidil for at least 3 years, and a significant proportion of patients in this study were followed for 5 years. And they looked at photographs and various scales assessing hair improvements. So 51 women in this study, the average age was about 50 years at the start of treatment. Patients were receiving sublingual minoxidil. Some were receiving anti-androgens as well, including spironolactone and bicalutamide. The dose of sublingual minoxidil was increased, starting at around 0.44 milligrams daily, and the final mean dose was 2.6 milligrams daily. And so that's an important number because those doses of sublingual minoxidil are, for women, are pretty good doses, pretty high doses. Now, fortunately, in this study, women did quite well, and side effects were, quite minimal. But as we go through this study, it's important to keep in mind that 2.6 milligrams of sublingual minoxidil, pretty high doses. Not everyone will tolerate that. But nevertheless, the information here is critical for us to know. After 3 years of sublingual minoxidil, 47% improved, 47% remained stable, 6% worsened, and after 5 years, 65% improved, 29% were stable, and 6% worsened. So you can see that between 3 and 5 years, there's further improvement in hair with sublingual minoxidil. And so these effects are sustained and improvements can occur. 45% of women in this study had hypertrichosis or excessive hair. 6% had lightheadedness, 2% had palpitations. And those are 3 of the well-known side effects of systemic minoxidil. This is a really important study because it shows us that these are durable results. That when patients come back to the clinic after 6 months and 9 months and they say, look at my hair, it's so much better. I'm worried, am I going to keep this? Is this just a coincidence? Am I going to actually keep this hair? This study reminds us that if the minoxidil is continued, the results should be sustained. And in fact, in some patients, there may be further improvements in hair density. And so patients can achieve sustained results and even further benefits over time. In this study, minoxidil was quite well tolerated. Hypertrichosis was seen in about half of patients and a share of patients that were dizzy. The doses here are somewhat high, and some women do tolerate 2.6 milligrams of sublingual minoxidil, but not all women do. And so I think that's really important as clinicians reflect on these studies, that it's not always about what dose you have to get to. And in this study, they started slow. 0.44 was the starting dose, and patients are often titrated upwards, depending on what's tolerated. But not all patients tolerate high doses. And for oral minoxidil, patients often do really well on 0.5 and 1 and 1.5. And as you go beyond that, some patients do just great, but not everyone does. Fluid retention, hypertrichosis, palpitations can start setting in. So we do have to be aware and cautious of these higher doses. But certainly in this study, higher doses were reasonably well tolerated and patients had some very, very nice outcomes. So this study gives us confidence that these long-term effects of minoxidil are sustainable. And in fact, there's no reason to believe that patients, if they're tolerating it quite well, can even have further benefit over time. These long-term studies are so important. There's very few studies in our hair loss world that go to these lengths in terms of the number of years of follow-up. And these are critical to supplying our field with high-quality data. And, you could probably count on your 2 hands the number of studies in androgenetic alopecia that extend, towards 5 and 10 years. So these are important studies, and I thank the authors for these types of meticulous work. From minoxidil, we move to finasteride. And I'm going to start with two studies that I really, really like. These are studies that tell us that anti-androgens like finasteride and dutasteride do not seem to be associated with an increased risk of breast cancer. And some studies looked at gynecologic cancers as well. This is really important data, which absolutely changes the counseling that goes on in the clinic. And as we get these studies that come in, we've had 3 studies in the past showing us that spironolactone does not cause breast cancer, or at least it's not associated with any type of a risk. There were 2 studies last year that we talked about showing that finasteride and dutasteride did not increase the risk of breast cancer. And in fact, one study suggested that maybe finasteride even lowers the risk of breast cancer. And now we have 2 studies that support that show that the risk is not increased. And as this data comes in, it's easy to forget what it was like practicing 10 years ago, 5 years ago, where an important counseling that went on in the clinic was, we're not sure if these drugs increase the risk of cancer. And these were an important part of the dialogue that went on. And so now we have 3 good studies with spironolactone and these 4 or 5 good studies with anti-androgens. Really, these are important changes in our field. So this first study by these authors from Weill Cornell, last author here, Dr. Lipner, was published in the International Journal of Dermatology and showed that finasteride, dutasteride, and spironolactone do not increase the risk of breast, ovarian cancer. So let's dive in. Anti-androgens are used off-label in the treatment of female pattern hair loss, meaning they're not FDA approved. Only topical minoxidil is FDA approved for women. But certainly spironolactone is commonly used in pre- and postmenopausal women, and finasteride, dutasteride are options that are commonly described in postmenopausal women, and in certain select cases in premenopausal women as well, although they can be teratogenic, harmful to a developing fetus. So women of childbearing age require a significant amount of caution with all treatments. Finasteride, dutasteride, of course. Spironolactone, yes. Oral minoxidil, yes. Topical minoxidil, yes. But we know that the 5-alpha reductase inhibitors are teratogenic. There has been concern in the past about whether these drugs cause or contribute to cancer. We know that finasteride and dutasteride have the potential to affect hormone signaling, and they have the potential to, at least in some studies, increase estrogen metabolism and increase the amount of estrogen available to tissue. And so the question has always been, if there's a little more estrogen around, then would there be any problem in estrogen-sensitive tissues like breast, ovarian, and other gynecologic tract tissues? And so these authors used a large database to dive into this question. Is finasteride, dutasteride, spironolactone associated with an increased risk of cancers or not? And so they performed a retrospective study over a long period of time using a very big database, looking at female patients that were diagnosed with androgenetic alopecia, as well as other non-scarring hair loss. And they looked at patients that were receiving finasteride, dutasteride, and spironolactone, and compared it to women receiving minoxidil as a control group. And these groups were matched. Those receiving anti-androgens were matched to those receiving minoxidil for a variety of factors that were factored into this exquisite statistical analysis that was done. And they looked at the risk of breast, ovarian, and uterine cancer, as well as benign breast, uterine, and ovarian tumors. Huge study. One of the things that I love about these large databases that can be offered now is the large number of patients that can be studied. And today we'll look at a number of studies with these massive databases. Here they looked at 11,783 women exposed to finasteride dutasteride, almost 7,000 women exposed to spironolactone, compared to almost 27,000 women on minoxidil. And after matching, the demographics were similar. And all in all, when they compared anti-androgen exposed patients to minoxidil exposed patients, there was no significant increased risk of breast cancer, ovarian cancer, uterine cancer. Very reassuring data. What was interesting in this study was that there was a very slight increased risk of benign breast tumors with spironolactone. And that met the statistical cutoff. And I think that's really important. And not all studies have shown that. And in fact, the next study, which we'll look at, found that there was no difference in benign breast tumors. But it's interesting to me because there has been a hint of data in past literature many years ago in some males, for example, that had received spironolactone for treatment of heart failure, and a case report of a male with fibroadenoma-like proliferations with spironolactone. And certainly that topic has come up a few times over the last many years with patients. Fibroadenomas are common, benign breast tumors in women. And the question is often, did spironolactone cause these fibroadenomas? Well, it's hard to say. Many women develop fibroadenomas. Yeah, but do you think the spironolactone made it worse or made more or made them bigger? The answer is we don't know. But this is an important study because it's really one of the first studies which has addressed the possibility of a statistically significant increase in benign breast tumors with spironolactone. Again, not supported in other studies, but I think it's important because it just sets the stage for better studies to be done, more studies. So this study by Dr. Lipner is so important because it really adds to this growing body of literature that there's no signal for increased risk of breast, ovarian, and uterine cancer with these anti-androgens. And that's consistent with these 3 prior studies with spironolactone and 3 or 4 prior studies with anti-androgens. And again, we need more studies with the benign breast tumors. What do we do with that information? But this is important because it gives us some reassurance, at least in women with average risk. These are really important studies. 1 in 9 women will develop breast cancer. And so these conversations are extremely important. What we don't know, and I think an area where our hair loss community has not thought more about yet, is what about women of high risk? What about the use of these medications in women with high risk for breast cancer, ovarian cancer, uterine cancer? And the answer is unknown, and I think more studies are needed. But certainly in women of average risk, there does not seem to be an increased risk of cancer. Very, very reassuring data. And I thank the authors for these important studies. This was another study looking at the risk of breast, ovarian, and gynecologic cancer in women receiving anti-androgens. Paper in the Journal of the American Academy of Dermatology. This study showed that, again, that finasteride and dutasteride didn't seem to be associated with an increased risk of breast cancer. And in this study, benign breast tumors were not increased. So the purpose of this study, like the prior study, was to determine if 5-alpha reductase inhibitors are associated with an increased risk of benign and malignant breast tumors. This was a different study. Instead of diving into a large database, this study was a retrospective cohort study at a single center. They were able to identify 810 women that were prescribed oral 5-alpha reductase inhibitors, and they matched them to over 5,000 patients that were not receiving 5-alpha reductase inhibitors. The median age of patients here was around 60. 2/3 of patients were white, 9% Black, 4% Asian. There were 713 patients that received finasteride. Majority of those on finasteride were receiving 5 milligrams, which is a very typical dose used for androgenetic alopecia in women. 12% were receiving dutasteride. Certainly dutasteride, not as commonly used of an anti-androgen, but certainly is very much used. The follow-up duration here was almost 4 years. Here's the key. The key is that the incidence of breast cancer was similar between those receiving finasteride, dutasteride, and controls. And there was no increase. The same was true for benign breast disorders, that the incidence was similar. Again, reassuring data that finasteride and dutasteride do not seem to increase the risk of malignant breast disorders, and in this study, benign as well. So really, really reassuring studies, now numbering 5 or 6, depending on how you interpret them. But just in the last 2 years, we have had an enormous number of studies looking at cancer risk with finasteride and dutasteride, all coming back extremely reassuring. This is important data. We didn't have this data before. And with this type of data, we really can provide a whole new level of reassurance to patients that provided that your risk of breast cancer is average in the population, there is no evidence that these drugs increase your risk of developing breast cancer. So really, really important data. And I think that these studies are really going to change the type of counseling that goes on in clinics around the world and the discussions that take place. So I thank the authors for these important studies. We move on to another study, this time looking at finasteride and dutasteride in men. Here is a study from Thailand, and a study which looked at men receiving 1 milligram of finasteride daily and comparing it to men receiving 0.5 milligrams of dutasteride 3 times a week and 2 times a week. You know, dutasteride has a very long half-life. And one of the things about dutasteride is that one pill of dutasteride can stay around quite a long time, opening up the possibility that less frequent dosing may achieve some pretty beneficial results. But good studies like this have not been done until this type of study came around. And the key point of this study was dutasteride 0.5 milligrams 3 times a week was pretty similar to finasteride daily and better than twice a week. So a really important study which shows us that, wow, 3 times a week dutasteride can achieve some pretty good results, comparable to daily use of finasteride. The other important point of this study was that sexual side effects were low in the finasteride, dutasteride groups, and similar. So let's dive into this study. In men, minoxidil is FDA approved topically. Finasteride is FDA approved. Dutasteride is not approved by the FDA in the United States, but certainly is approved by a number of regulatory bodies around the world for treating androgenetic alopecia, and is certainly used off-label in much of the world for treating androgenetic alopecia in men. Finasteride blocks 5-alpha reductase type 2, and dutasteride blocks type 1 and type 2 5-alpha reductase. And on account of its dual blockade, DHT levels are lowered even more. And this DHT, or dihydrotestosterone hormone, is thought to be very important in androgenetic alopecia. And when you block it, you remove a hormone which is contributing to balding. All discussions around finasteride, dutasteride involve at one point or another discussions around sexual side effects. And because of the long half-life of dutasteride, the question has arisen whether it is possible to get good results with less frequent dosing, and would side effects be less as well. So the purpose of this study was to evaluate whether twice a week or 3 times a week dutasteride was effective and safe, and how it compared with daily finasteride in men with androgenetic alopecia. Here, a wonderful study from Thailand published in JAAD International. So it was a prospective randomized trial lasting how long? 24 weeks. That's our number, 24 weeks. 60 Thai men aged 21 to 60 with Hamilton Norwood 3 to 5. And there were 3 groups: a dutasteride twice a week, a dutasteride 3 times a week, and a finasteride daily. And they looked at a whole bunch of measures: hair density, global photography, how satisfied patients were, as well as side effects. The average age of patients was about 34 to 37. Most were very healthy males with androgenetic alopecia for several years, with Hamilton Norwood stage 3 to 5. Most patients completed the study. 1 withdrew because of sexual side effects, and that was a patient in the finasteride group, and 1 dropped out of the study. Here's the key point. Finasteride, dutasteride twice a week, and dutasteride 3 times a week all seem to help male balding. But some of the greatest results appear to be with dutasteride 3 times a week. Now, when you actually crunch the numbers and look at the actual hair growth, it was pretty similar with dutasteride 3 times a week and finasteride daily. But the key point is that dutasteride just 3 times a week stacks up quite well compared to finasteride daily. And so it's a very reasonable treatment. When we actually looked at improvements and how patients felt they did, there was a suggestion that patients in the dutasteride 3 times a week group seemed to do even better, but those numbers were quite small. Side effects were mild and comparable. In terms of sexual side effects, 5% of males in the dutasteride 3 times a week had side effects, 10% in the twice a week, and 15% in the finasteride daily. And so certainly an important statistic showing us that dutasteride 3 times a week is well tolerated, and certainly performs as well as finasteride daily, with a hint, just a hint, that maybe it could even be better in some parameters. So intermittent low-dose dutasteride works, and dutasteride 3 times a week certainly can be viewed as quite comparable to finasteride daily. Side effects were quite comparable, and these authors stated that the medication was well tolerated. This is a real important paradigm shift in our thinking of how dutasteride fits in the management of androgenetic alopecia in males. With this study, at least in Thai men, that finasteride 7 times per week seems to be comparable to dutasteride just 3 times per week. Is dutasteride daily better than finasteride daily? Well, we already know that data. We already know that data from studies that were done quite some time ago, that answer is yes. The potential exists for less frequent dosing, that we can still achieve some pretty good results and potentially have less potential for side effects. So those types of studies need to be repeated in other centers, as all good studies do, and followed long term. But at least over 24 weeks, this is very reassuring data that 3 times a week dutasteride seems to be quite well tolerated. And there's other studies in our literature which show us that males taking dutasteride 3 times a week have less side effects than males taking dutasteride daily. And so this is really reassuring data that this may be an important strategy for management of androgenetic alopecia. Look for more studies in this low-dose intermittent dosing strategy. And so this is a really important study. It really gives us new thoughts in terms of how treatment may be started, especially treatment, for example, in men concerned about dosing and frequency of dosing and concerns about sexual side effects. Using infrequent dosing of dutasteride, like 2 or 3 times a week to start out, can still be quite effective for the management of androgenetic alopecia and opens the door to increase down the road, depending on how someone does. But patients using these doses can be reassured that they're achieving good benefits. So thank you to these authors for such wonderful data that really enhances our understanding. We move on now to another nice study in androgenetic alopecia, this time looking at the pathogenesis, this time looking at the mechanisms that cause androgenetic alopecia. And this is a wonderful study by Asfour, published in Clinical Experimental Dermatology, which shows us that hair shedding is very much a part of the early stages of androgenetic alopecia. And hair shedding is what you see initially, even before hairs miniaturize. We know that androgenetic alopecia in men and women is all about the progressive miniaturization of hairs, the progressive conversion of big hairs, 70, 80 micrometer hairs thick, into 50 micrometers, 40 micrometers, 30 micrometers, 20 micrometers, smaller and smaller and smaller. We call that miniaturization. And we focus so much on miniaturization. It's certainly very important. But this study reminds us that the first step in androgenetic alopecia is probably not miniaturization of hairs. It's the shedding of hairs. And so this is such a wonderful study which really changes our thinking that shedding happens first. And shedding happens because the anagen duration or the growth duration starts reducing. So instead of hairs living on your scalp for 6 years or 7 years, hairs start deciding that I'm only going to live up here for 3 years or 2 years or 1 year. So the duration of the growth phase starts shrinking. Hairs are still big caliber in this early stage, but the growth phase duration starts dropping, and that's associated with shedding. Whenever you decrease the duration of anagen, you increase shedding. And so this paper reminds us that that is the first stage. And so really a focus on getting hairs to keep growing, growing, growing. Don't shed, don't shed. Don't reduce your anagen phase may be very relevant to how we treat androgenetic alopecia. And so it has long been known that shedding is relevant in androgenetic alopecia, and it has long been known that miniaturization is relevant. But what hasn't been known or well characterized is which comes first. Do you get skinnier hairs and then they shed more? Or do you shed more and then eventually you get skinnier hairs? Well, this study tells us that it's the latter. And so the purpose of this study was to determine whether a shortening of anagen phase comes before or after miniaturization. And so it was a really brilliant study looking at this in more depth by carefully following hair caliber and shedding parameters over time. And so they studied men with androgenetic alopecia, and they followed trichograms on the scalp at the beginning of the study at day 84 and at day 112. And they stared at these hairs. And they looked at what happens to the hair shaft diameter, the growth rate, the anagen duration, and the telogen duration. Classic hair studies. You know, there's very few people in the world that know how to do such intricate work with a phototrichogram that really allows these types of answers to come. So these were all men in this particular study, ages 18 to 55, Hamilton-Norwood scale balding 3, 4, 5. And 50 males were analyzed in a larger subset. There seemed to be quite a correlation between the diameter of a hair fiber and the anagen duration. But here was one of the most important parts of this study, that even thick hairs on the scalp in males that were balding had a surprisingly shortened anagen duration. In non-balding men, the duration was about 739 days. In balding men, the duration was 580 days, so less, even in hairs that were thick. So even in hairs that are thick but undergoing the process of balding, they get a reduced anagen duration. In thin hairs that were already well on their way to balding, the anagen duration was even more reduced, 200 days. The telogen duration stayed constant, and as hair diameter decreased, the growth rate decreased. And so this study really teaches us that one of the first stages in balding is a reduction in the anagen duration. In this case, instead of being over 700 days, it becomes more like 500 days. And it's a change in diameter that comes later. So miniaturization comes later. And so these authors propose that one of the first stages in balding is shedding. Shorten your anagen phase, get hair shedding. And that's important even before miniaturization. And so this represents it pictorially, that this hair in the middle is undergoing balding. But yet when you look at it, you would think, it doesn't look like it's undergoing balding. It's just as thick as it started out with. It is just as thick, but its anagen duration is less. It's not willing to live on the scalp quite as long. And it's shedding more likely. And that's the first stage in balding. So really an important study, this study in clinical and experimental dermatology, which teaches us that the early stages of balding are about shedding. And this is a really important study because shedding is so important in androgenetic alopecia. And so when women come in and men come into the clinic and they say, you know, I'm shedding, the first thing we must think about is this could be androgenetic alopecia. The problem is that in the world, most clinicians think, you're telling me you have telogen effluvium. Let's check your iron and your thyroid and your, ask about dieting and weight loss. That is relevant. Of course, we need to ask about that. But we forget that shedding is the very first stage of androgenetic alopecia. And so males that come in and say, I'm shedding so much. I got hair on my shower walls. I got hair in my brush. Yeah, but your hair looks pretty good. I don't see any miniaturization. It still can be androgenetic alopecia. Shedding is the first stage of androgenetic alopecia. And this study corroborates that. And this study really pushes us that much more ahead to understand where shedding fits in. I thank the authors for this brilliant study and these important studies which teach us all how to do these good studies with phototrichograms that are really so important in our field. And this study also reminds us that although treatments that block DHT are relevant, treatments that help prolong anagen phase are also relevant. And treatments like minoxidil may be very relevant as mechanisms in thinking about androgenetic alopecia. And certainly we know from good studies that have been done in the past that the best treatment for androgenetic alopecia in males is dutasteride. Nothing comes close. But certainly honorable runner-ups are minoxidil. Oral minoxidil, for example, 5 milligrams. In a study not too long ago by Dr. Gupta from Canada, taught us that oral minoxidil is an honorable runner-up, silver medalist. And this study really reminds us that, if we can support the anagen phase, try to reduce shedding, maybe we can do something very positive in the management of androgenetic alopecia. So I thank the authors for this study. Really an important study, and I just love the title. Most titles in our field are very factual. Look at this title. You cannot go bald without losing your hair. Telogen effluvium is a precursor to prerequisite for, and potentially an incitant to common baldness in men. That'll go down in history as one of the great titles of our papers. We move on from androgenetic alopecia into some wonderful studies in telogen effluvium. We have all heard that these new weight loss medications, these GLP-1 receptor agonists and GIP agonists, semaglutide, liraglutide, tirzepatide, can cause hair loss. And there is a lot of controversy still on December 29th, 2025, about how likely they are to cause hair loss, how many get hair loss, does it grow back, when does it occur? We don't have all the answers yet. But what we do know is that a certain proportion of patients that use these weight loss drugs will lose hair. And I think that we have a lot of bias because we feel that we want it to be a very simple story. We don't like uncertainty as clinicians nor as patients. And so a view that tries to permeate the literature is you go on these drugs, some people lose hair. They lose hair because they're losing weight. Once the weight stabilizes, all the hair grows back. That's the story we'd like to have. The reality is that when you look at patients on these drugs, you realize that some people don't fit that paradigm. There have been a lot of studies looking at FDA adverse event databases and other ways of looking at hair loss from these drugs. But a study I'd like to introduce you to here is a really important study which looks at a single center and looks at what's happening to about 300 patients on these medications. And I think is one of the early studies with looking at hair loss from these GLP-1 receptor agonists, GIP agonists, and really has some important messages for us. And this study, if we choose to look at the data, really has some important considerations. That maybe this is not all just a telogen effluvium, and once your weight stabilizes, it all grow back. That's what we'd like it to be. But this study is one of the earliest studies which reminds us that it might not be that simple. And other studies now have corroborated that some patients get a telogen effluvium, but some patients get a worsening of androgenetic hair loss. Telogen effluvium may be reversible. A worsening of androgenetic alopecia is not always reversible. And these are important studies which really change our thinking, that provide some data that really, I think, as a hair loss community, we all have to face up to the possibility that not everyone returns to the exact same density that they started with. The hope is that they do. So the key point of this study is that hair loss occurs in between 10 and 15% of patients using these weight loss drugs. Certainly some patients developed a telogen effluvium, but some patients in this study developed a worsening of androgenetic hair loss. And that's what really makes this study so unique, is that it really was one of the earliest studies to say, you know what? I'm going to report what I see. I'm not going to try to mold this into a story of these weight loss drugs cause shedding, telogen effluvium. I'm going to report what I see. And that type of study is so valuable. That's why I love this study. So these drugs have really taken over the world. I think you're pretty hard-pressed not to know someone who's on a GLP-1 receptor agonist. And it's very clear that these drugs cause hair loss in some patients. And so the purpose of this study was really to characterize that more. So it was a retrospective cohort study from the University of Miami, analyzing dermatology patients that were on these drugs for a 3-year period. And they looked at the patients, the demographics, the type of GLP-1 receptor agonists they were on, as well as other characteristics. There's 283 patients. And remember, this study came out early last year, submitted before, and so we're dealing with some of the early days capturing this number of patients. That's really important. At a single center in those early days to be able to capture 283 patients is a big deal. It's very significant. 65% were female. The average age was 56. The majority of patients were overweight or obese, and 3/4 of patients lost weight. Semaglutide and tirzepatide were among the most common GLP-1s, GLP-1 GIPs. 12% got hair loss in this study. It was a brand new hair loss in 1.2% of patients and a worsening of hair loss in 12%. This slide is among the most important, and that is that the types of hair loss that are problematic to these patients is a telogen effluvium, as we expect, but also an androgenetic alopecia and a worsening of androgenetic alopecia. And in this particular study, they had patients with other issues that came up as well. They were small, and so the significance of them isn't clear. But it showed that, the story of hair loss from these drugs is telogen effluvium, but it's also androgenetic alopecia. And it's easy to try to want to ignore that data. I don't know what to make of that data. Let's just focus on the telogen effluvium. But I think that's so important. They found a trend towards an increased risk of androgenetic alopecia with semaglutide, and a significant association, a borderline association with tirzepatide causing a telogen effluvium. So a really important study. 15% of patients in this study get hair loss from these drugs. And that's been corroborated in other bigger studies. That seems to be a pretty good statistic. The story of hair loss from these drugs is a story of telogen effluvium and androgenetic alopecia. And more studies are needed to better understand this. But I think that's so important, because the early literature and these GLP-1s really focused on telogen effluvium. These drugs cause shedding. Once your weight reaches a stable area, you get your hair back. That's true for some patients, but it may not be true for all patients. And so stay tuned. More great studies are coming that really remind us of this complexity of these drugs. And I think as we continue to use these drugs longer, we'll have better understanding about the relative risks between these various drugs, semaglutide, liraglutide, tirzepatide, and specifically what to make of the androgenetic hair loss that may be worsening or coming from these medications. So the story's not done yet. But I think it is important to counsel patients about the risk of hair loss from these drugs. And I think that it's difficult now in 2025 to say, you'll get hair loss, but once your weight stabilizes, it'll all come back. It certainly will for a lot of people, but it may not for everybody. And someone with active androgenetic alopecia to begin with, who starts these medications, it is possible there could be an activation and an acceleration of androgenetic alopecia that, without treatment, may worsen. So more studies are needed. How do we prevent hair loss from these GLP-1 GIPs? That's coming. Stay tuned. But thank you to these authors for this very important study, which really is such in some senses, a direct study, but a really important study because it reports what you see. And I think that's how good studies are done, that you don't try to force any observation into a package. You simply report what you see. And that's what was done here. So Thank you so much to these authors. We move on now to alopecia areata. 4 wonderful studies in alopecia areata. Alopecia areata is an autoimmune disease. It's an autoimmune disease where the immune system is attacking the hair. And it can be hair anywhere: scalp, eyebrows, eyelashes, body hair. Some patients develop a single patch on the scalp that grows back even without treatment. Some patients develop more extensive hair loss. Alopecia areata can affect children, it can affect adults, it affects people all over the world. The first study is an absolutely fascinating study, teaching us that early exposure to antibiotics in children might increase the risk of them developing alopecia areata. It's a study from Korea published in the Journal of Investigative Dermatology. The key point of this study is twofold. The first is that exposure to antibiotics in the first 2 years, especially when you're getting multiple classes of antibiotics and longer duration, gives you an increased risk down the road of getting alopecia areata. The second is that timing is critical, and exposure in the first 12 months of life seems to be even more relevant. So we open this discussion with a reminder about the gut microbiome. We have this incredible accumulation of bacteria as well as other organisms in our guts. 2 or 3 kilograms of microorganisms. These microorganisms in our microbiome, in our gut, are little factories. They produce all these hormones and chemicals, and they play an absolutely critical role in keeping us healthy. We need them. We need those microbiomes. And what's been very clear in alopecia areata is that the microbiome seems to be changed in patients with alopecia areata compared to people that don't have alopecia areata. It's not consistent, so the studies don't show that it's one change only. It differs depending on the study. But some studies have even gone on to show that if you improve the microbiome, sometimes you actually improve the treatment of alopecia areata. So it's a reminder that these organisms in the gut are really important. They talk to the immune system, they produce chemicals that balance the immune system or keep it in check. It's also very clear that the early days of the microbiome in infants is really important to the collection of immune and other diseases that might happen later in life. And studies have shown that babies that are breastfed may develop a different microbiome than babies that aren't breastfed. And this may change slightly the immune diseases that can occur. And so these authors from South Korea really wanted to better understand if young infants are given antibiotics, which we know dramatically alters our microbiome. If they're given antibiotics and all that microbiome is disturbed, and if the microbiome is supposed to be so important in how it communicates with the immune system, does this set up the possibility to develop immune diseases? In this case, focusing on alopecia areata. And so the purpose of this study was to determine whether antibiotic exposure in the first 2 years of life increases the risk to develop alopecia areata down the road. There's a lot of places in the world where they have wonderful databases of studying large numbers of patients. And South Korea is one of them. And there's just some wonderful studies that have come out of South Korea by a better understanding of large patient numbers. And here, 3,780,000 children from South Korea were studied in this particular study. Antibiotic exposure was studied over the first 24 months of life, and children were followed from that age until the study was complete. They used coding in the computer to verify that these patients indeed had alopecia areata or not. And they used statistical analysis to control for a number of parameters that may confound the data to really get the most accurate picture of whether antibiotics increases the risk of alopecia areata. So over this large number of patients, 3.7 million studied for a long period of time, there was 9,000 that ended up developing alopecia areata. And here's the key to the study. Higher exposure to antibiotics increased your risk of developing alopecia areata. If you received in your life during those first 2 years more than 3 types of antibiotics, your risk went up. If you were on antibiotics more than 30 days, more than 90 days, your risk of alopecia areata went up. And early exposure had particular relevance, and exposure within the first year of life was associated with a significant increased risk. So the more antibiotics you got, and the earlier your exposure, your risk of alopecia areata was increased. A really important study, which forces us to really face some challenging concepts, and that is that our developing microbiome is so important, and that antibiotics in the first 2 years of life is increasing your risk of alopecia areata. The presumption here is that those antibiotics are affecting your microbiome. Now, of course, those exact changes need to be studied, but that is the presumption here, is that that is one of the important things that these antibiotics are doing. And so it really reminds us all that, careful and judicious use of antibiotics, or what we call antibiotic stewardship, using antibiotics only when you need to, and if you don't use them, that's what we call antibiotic stewardship, is really important in helping to reduce the risk of some of these autoimmune diseases. And so a really important study that really sets the stage for further studies to really understand how we might prevent this, how we might support the microbiome, what are some kind of things that we might do in general in patients receiving antibiotics. The literature on probiotics and prebiotics is quite controversial. Despite how much we would like it to be straightforward, it's not. And so we need more studies to really understand how we can support this microbiome that we all have, which is so critically important. So thank you to these authors for this really wonderful study, which really sets the stage for more studies and understanding how changes in our microbiome are affecting our immune system. We go on to another study of the gut. This time a study looking at not celiac disease, not Crohn's disease, not ulcerative colitis, but microscopic colitis. Microscopic colitis is a group of chronic inflammatory bowel conditions that include lymphocytic colitis and collagenous colitis. And these are types of chronic inflammatory bowel diseases that seem to be increasing in the world. And certainly the number of times in a given 2-month period or 3-month period that I hear the word collagenous colitis or lymphocytic colitis has dramatically increased over the past decade. And this study really sought to understand whether microscopic colitis is increased in patients with alopecia areata. And so when we think of chronic inflammatory bowel disease, we think about Crohn's and ulcerative colitis. These are certainly very important inflammatory bowel diseases that are increased in patients with alopecia areata. Attention on microscopic colitis is a lot less. And certainly the world is coming to understand this more because it does seem that these are becoming more frequently diagnosed. And the key point of this study is that patients with alopecia areata seem to be at increased risk to develop microscopic colitis. And it may occur in younger patients as well. So let's dive into this particular study. We can see in that study from South Korea that, the gut is so important. We know that patients with alopecia areata have a number of disturbances in the GI tract. There's an increased risk of celiac disease. Patients with celiac disease have an increased risk of alopecia areata. Patients with alopecia areata have an increased risk of celiac disease. There's an increased risk of inflammatory bowel, irritable bowel syndrome. There's an increased risk of inflammatory bowel syndrome disease. So a real understanding of alopecia areata really places an important understanding on the gut and gut health. It's extremely important. And this study really highlights microscopic colitis. This is a T-cell mediated disease of the colon, most often affecting older individuals. This study teaching us that maybe younger patients with alopecia areata can be affected. So the purpose of this study was to really better understand the association between microscopic colitis and alopecia areata. So they performed a retrospective cohort study using TriNetX, which is this global massive research database that many researchers are using, which has a large number of participants from the US, but also from South America, Asian Pacific area, Europe. So it really is a global database. And patients with alopecia areata were matched to patients without alopecia areata. And using statistical analysis, the risk of microscopic colitis and other gastrointestinal diseases was calculated. They identified 117,674 patients with alopecia areata, and these were matched to a same number of controls without alopecia areata. Mean age of patients was 33, 60% were female, and half were white. Here's the key part of the study, that patients with alopecia areata in this TriNetX study seem to have an increased risk of microscopic colitis, almost twofold. And that included both lymphocytic colitis and collagenous colitis. And in this study, there was an increased risk of microscopic colitis, celiac disease, Crohn's disease, ulcerative colitis, and another disease that also seems to be on the up and up, and that's eosinophilic esophagitis. Really emphasizing that this whole gastrointestinal tract is highly relevant to understanding alopecia areata. And in this study, patients with microscopic colitis trended to be younger and more often female compared to controls. And so a good reminder that alopecia areata is associated with Crohn's and ulcerative colitis, but also with microscopic colitis as well, both subtypes, and may occur in younger patients. Microscopic colitis can present with chronic watery diarrhea, often non-bloody, which differs it from classic Crohn's and ulcerative colitis. But I think these are important in our patients with gastrointestinal symptoms, that if symptoms continue, that patients are evaluated properly by a gastroenterologist, because all of these autoimmune diseases of the GI tract seem to be increased right from microscopic colitis, Crohn's colitis, ulcerative colitis, celiac disease, eosinophilic esophagitis. These are all increased. So we need to be thinking about these, and we need to be mindful of this, and that patients with chronic symptoms need proper evaluation to rule out these diseases. So I thank the authors for these important studies. I think we'll be hearing a whole lot more in our dermatology world about microscopic colitis and eosinophilic esophagitis. These diseases are increasing, and they're becoming much more a part of my everyday for reasons that I don't understand why. But I think we're becoming more aware of these diseases as time goes on. And so I thank the authors for this important study. We turn now to a really interesting study of oral minoxidil in alopecia areata. A lot of literature focuses on oral minoxidil for androgenetic alopecia. Here, oral minoxidil for alopecia areata, and a study that teaches us that oral minoxidil does something. And I think that's really important. The key point of this study is that oral minoxidil can help patients with alopecia areata, even patients with severe disease, and tends to be fairly well tolerated. Now, oral minoxidil in alopecia areata hasn't been studied all that much. There were some studies in the early days of both topical and oral minoxidil, dating back to the 1980s and early 90s, looking at the use of minoxidil in alopecia areata. In fact, some of the early literature on topical minoxidil focused on alopecia areata, not so much androgenetic alopecia. But this was an important study in 1987, which looked at 5 milligrams twice a day, pretty high dose of oral minoxidil, 5 milligrams twice a day. Typical doses in men, 2.5 to 5. Women, 1.25 to 2.5. So this is a high dose. They showed a improvement in 38% of patients with moderate hair loss. And in patients with really severe hair loss, 75 to 100%, even 10% of patients had some significant improvements with oral minoxidil. So these were some early studies which reminds us that even though oral minoxidil isn't specifically targeting the immune deficit in alopecia areata, it can be helpful in alopecia areata. So this study stayed in the history books and didn't receive all that much attention in the last few years. And as we all started using more and more JAK inhibitors, and as we all sort of found that patients improve with JAK inhibitors, but some of them don't improve fully. So what can we do to help? Well, we add oral minoxidil to JAK inhibitors. And the question that I had been asked time and time again over the last several years is, what is the data for oral minoxidil in alopecia areata? We've got all the wonderful studies of JAK inhibitors in alopecia areata, but what really is the data in oral minoxidil, and what do you have to back up that it does anything? And so this study now that I'll review with you by Dr. King's group really is an important study because it reminds us that, oral minoxidil does something good in some patients with alopecia areata and can be a helpful monotherapy or adjunct. So this is a really important study in our literature. So the purpose of this study was to evaluate the safety and effectiveness of oral minoxidil. So they reviewed 41 alopecia areata patients that were treated with oral minoxidil. The doses here ranged from 1.25 to 10. The median was 5. So there's some patients in this study that I will introduce you to that received some pretty high doses of oral minoxidil. That's important to keep in mind. It could be that there is a trend developing in our literature for higher doses of oral minoxidil and sublingual minoxidil to be used. But I think that's important to think about, that some of these studies have quite high doses. Some patients received minoxidil alone in these studies, and other patients were also on other therapies. And they looked at the changes in the SALT score, or the severity of alopecia scoring. There's 41 patients, small study, a very nice study. 25 females, 16 males. 90% had a duration of alopecia areata less than 4 years, which is important because we think that the less duration of alopecia areata, the more likely it is to grow or want to grow. 17% had patches of alopecia. 29% had quite larger areas of hair loss. And about 30% of patients had severe alopecia areata, 50% or more loss. Here's the key to the study, that for patients with patchy alopecia, 71% had an improvement in hair down to a very small amount. And as you went up with the amount of hair loss that a patient had to start with, you could see that the significance of improvement dropped, but still there was improvement. And for patients with severe alopecia areata, 25 to 30% of patients had some very nice improvements with the use of oral minoxidil. So I think that's really important, that oral minoxidil stands alone as a therapy, even in advanced alopecia areata. Now, it may not help, well, it does not help to the same degree as some other immunosuppressants, like the JAK inhibitors, but it still has a role. Oral minoxidil is much more widely available, cost is less, and is very much on the list as a treatment option for alopecia areata. And when you think about its ability to be used in conjunction with immunosuppressants without further worsening the degree of immunosuppression, it becomes quite a useful add-on and adjunct. But this study reminds us that alopecia areata can be treated and benefited by oral minoxidil alone, even in severe cases. So really a very important study which places oral minoxidil as an important treatment in our algorithms. And this type of data really hadn't been verified to this extent in a long time. The median time to response was 32 weeks, so it takes a while before we get hair growing with oral minoxidil. So if you give a patient oral minoxidil and they're wondering, when am I going to see the results? The answer is it can take a long time. It can take 4 months, 6 months, 8 months. And so that's important the patients stick with it before determining if this really has done anything. It's not that a patient will start oral minoxidil, see how they like it over the month, and if it didn't do anything, then stop. It takes a long time. Side effects in this study included hypertrichosis, swelling or peripheral edema, and lightheadedness. One patient developed pericardial effusion. She was on 5 milligrams twice a day. So she was on a relatively high dose. In this particular study, the median dose in these 41 patients was 5 milligrams. So half were 5 and higher, half were 5 and less. So this study tended to have patients on higher doses. And I think that's important as we think about this study, and the significance of this study is that perhaps this degree of improvement may not occur to the same extent on lower doses. So we do have to keep that in mind. Typical doses in men are 2.5 to 5. Typical doses in women are 1.5, 1.25 to 2.5. But, certainly there are some of our research studies in the oral minoxidil literature that are examining higher doses. And higher doses increase the risk of some of these side effects, like pericardial effusions in this study, edema, hypertrichosis, palpitations. So we do have to be aware of that. But a really important study which places oral minoxidil on the list as a treatment option in alopecia areata. If we're going to go higher, we certainly need to be very cognizant of these side effects that can occur. They can occur at low doses, but are much more common at high doses. So I thank these authors for this really important study, which really allows us to understand how oral minoxidil fits in the treatment algorithms of alopecia areata. So thank you. I think we'll be hearing a whole lot more about oral minoxidil in alopecia areata as we, really seek to understand how it provides a helpful adjunctive treatment, especially with our JAK inhibitors. So the two of them are quite commonly used together. We move on now to a really important study looking at the discontinuation of JAK inhibitors in pregnancy. This was a study in the International Journal of Women's Dermatology. This is a small study, but an incredibly important study. Women face a really important decision, and that is for women that have alopecia areata and are on JAK inhibitors and wish to become pregnant, the current guidelines are that JAK inhibitors must be stopped in pregnancy. And that almost universally leads to hair loss. And that hair loss that occurs is devastating. And so here we have patients that have regrown hair back and had these happy times of getting hair back and the joy of getting hair back. And now are moving forward with very happy feelings about starting a family, coupled with the unfortunate events of losing hair now because the JAK inhibitors need to be stopped. And these are very much part of the life of many patients on JAK inhibitors with alopecia areata that are in the years of childbearing. And these are discussions that I have, not a month goes by. And there are some patients that are very, very fearful of stopping JAK inhibitors and the fear of losing hair. And the question that arises is, will I get the hair back if I restart the JAK inhibitor after pregnancy? Now, what we know from many studies of JAK inhibitors is that when you stop JAK inhibitors, you lose hair to a significant degree. And what we do know from these great studies in the last 3 years is that no, not everybody gets their hair back to the same level when you restart. A lot of people do, but not everyone. And so the question that has arisen is, if you stop a JAK inhibitor for pregnancy and then you restart it after pregnancy, will you get your hair back to the same level you had before pregnancy? We did not have those answers until this study. That's why this is such an important study. And what this study showed is that hair loss occurs in most women after stopping the JAK inhibitor. And in those that restarted the JAK inhibitor after pregnancy, that hair returned to the same density, sometimes even better than before pregnancy. So it's a small study, but a very reassuring study that even women with severe alopecia areata will lose hair, but will get it back when they restart their JAK inhibitor after delivery, after breastfeeding. So I thank the authors very much for this really important study, which becomes very much a part of information that can be shared with women that are making some very, very tough decisions. And for some women, this is a very, very challenging decision about when to time this almost guaranteed loss of hair. And so there really hasn't been much data at all of starting and stopping JAK inhibitors around pregnancy until this study. And so this was a study which really sought to clarify some of these unknowns. And so they had 9 women with severe alopecia areata at a total of 14 pregnancies. These women previously responded very well to JAK inhibitors. Hair loss was evaluated before treatment, after starting the JAK inhibitor, after stopping treatment for pregnancy, and then after restarting it after delivery. Stopping a JAK inhibitor led to hair loss in all women. It varied to the degree of hair loss, but all women lost some hair after stopping, and some women lost a significant amount of hair. All women regrew hair after restarting, after delivery. And women either achieved the same or better density than before pregnancy. And so this just shows changes in SALT scores for those that like graphical data, that SALT scores in some of these women were quite high before starting a JAK inhibitor, 80, 90, 100, down to very low after starting a JAK inhibitor. After it needed to be stopped for pregnancy, there was hair loss, some experiencing mild increases in loss, but some going back to severe forms of hair loss. And after resuming the JAK inhibitor again after pregnancy, you can see that the SALT score dropped again. And some of these patients with severe alopecia returned to severe alopecia, but then returned again to excellent growth. So a really important study which gives us valuable information to share with patients. That unfortunately you will lose hair by stopping these medications for pregnancy, but absolutely you can be hopeful that you will regain that hair after delivery. And that's really, really important data that we just did not have. And so I thank these authors. You know, it's a small study, but it's not easy to find 14 pregnancies where you can analyze data before, after, during so meticulously like this. This is a really wonderful study and a unique study, and there is no study like this. So I thank the authors. The use of JAK inhibitors in pregnancy is something that is not allowed at the moment, but continues to be actively studied. And the companies that manufacture JAK inhibitors are, you know, really interested to understand the safety of JAK inhibitors in pregnancy. And there have been studies looking at JAK inhibitors in pregnancy. Even though it is not a recommended option, there have been studies examining this issue. And the data to date in the, several hundred women around the world over the past 10 years who have become pregnant with exposure at different stages in their pregnancy has tended to be good, supporting that, maybe, just maybe, the safety is okay. We don't have that data sufficient yet to make that a recommendation. And so currently the recommendation is that JAK inhibitors should be stopped. But stay tuned. There will be an increasing amount of data in the next few years about whether or not JAK inhibitors are safe in pregnancy or not. But for now, we have important studies like this, which really give us important information for counseling patients that are making some really important decisions about family planning. So thank you very much to these authors. We move on now to some studies of seborrheic dermatitis. Seborrheic dermatitis is a common condition. 5% of the world has seborrheic dermatitis. 50% of the world has a close cousin called dandruff. Seborrheic dermatitis is red and scaly and itchy and sometimes burning. Severe seborrheic dermatitis can be associated with shedding. There is an increased association between certain yeast in the scalp, malassezia, and seborrheic dermatitis, and eradicating these with anti-dandruff shampoos can be very helpful for many patients. But it's an inflammatory disease, and you can see on this picture that it's red and scaly. This is an inflammatory disease. Seborrheic dermatitis is fascinating because an increasing amount of data over the last 5 years has really been looking at some associations with seborrheic dermatitis. We know that patients with depression are at increased risk for seborrheic dermatitis. Patients with HIV on certain medications are at increased risk. Parkinson's disease patients are at increased risk. Certain medications, stress, altitude. We've come to understand a lot of these associations with seborrheic dermatitis. And seborrheic dermatitis is taking a whole new turn where it's really gained a tremendous amount of interest in studying seborrheic dermatitis and a whole new interest in understanding the associations with seborrheic dermatitis. And a realization that seborrheic dermatitis may not just be this itchy scalp condition where you need a dandruff shampoo, but it may be associated with other conditions. And so this particular study looked at some of the diseases of the eye, gastrointestinal system, and other epithelial tissues, and whether certain diseases may be increased in patients with seborrheic dermatitis. This was a very nice study in JAMA Dermatology titled epithelial barrier diseases among adult patients with seborrheic dermatitis. And the key point of this study is that patients with seborrheic dermatitis have an increased risk of these so-called epithelial barrier diseases, skin diseases as well as non-skin diseases. And those diseases include atopic dermatitis, alopecia areata, psoriasis, rosacea, celiac disease, IBS, dry eyes. And these data support this notion that when you break down the skin barrier and you get inflammation in the skin barrier and you lose skin barrier function, you set up the immune system for other diseases to take place. And this concept of the epithelial barrier theory proposes that when you disrupt the epithelium of various tissues and expose the immune system to this disrupted epithelia, that you trigger the immune system to be ready to go and cause problems at other sites. And so when you disrupt the skin, maybe, just maybe, you set up the immune system for problems in the gut, respiratory tract, eye, skin. And until now, this exact relationship between seborrheic dermatitis and diseases of the epithelial barriers of the body have been not well understood. And so the purpose of this study was to evaluate whether patients with seborrheic dermatitis are more likely to have some of these epithelial barrier diseases compared to controls. And so it was a retrospective cohort study with over 20 million adults studying from the years 2016 to 2022. And patients with seborrheic dermatitis were compared to controls, adjusting for a number of variables factored into this statistical analysis. Of these 20 million patients, 700,000 had seborrheic dermatitis. The median age of patients was 63. About half were female, and they were followed for about 4 years. Here's the key to this study, this JAMA dermatology study that just came out. The patients with seborrheic dermatitis had an increased risk of atopic dermatitis, alopecia areata, psoriasis, rosacea, hidradenitis suppurativa. And not only did patients with seborrheic dermatitis have an increased risk of these skin issues, but it had an increased risk of these non-skin issues at these other epithelial sites. Rhinosinusitis, celiac disease, irritable bowel syndrome, ocular allergy, and dry eyes. So really setting up seborrheic dermatitis as this complex multi-system disease. That yes, it's fair to think of seborrheic dermatitis as a cousin of dandruff, but it's a cousin which is a very complicated cousin. Seborrheic dermatitis is associated with all of these other inflammatory diseases. And I think it's really shifting the focus of seborrheic dermatitis, similar to how we've seen the focus of psoriasis change in the past 15 years. That seborrheic dermatitis really is this much more complicated multi-system disease. And this epithelial barrier theory really proposes that, this inflammation going on in the skin is programming the immune system to potentially cause problems at other sites. And so I think this is a fascinating study which really positions seborrheic dermatitis a little differently than a condition where we just put a little dandruff shampoo on it and be done, but rather a multi-system disease associated with complex disorders. And these authors, last author Margolis, have done some, really fascinating work, not only in this JAMA dermatology study, but in other studies like the one I have on the screen here. And in this particular study, they found this bidirectional relationship, which I find quite fascinating, where seborrheic dermatitis not only increases the risk for these epithelial disease, dry eyes, irritable bowel syndrome, psoriasis, rosacea, but having those epithelial barrier diseases increases your risk to develop seborrheic dermatitis. So it's a bidirectional relationship. I think that's really interesting, and I think we'll be hearing a whole lot more about seborrheic dermatitis and how it really positions itself as really a highly complex disease. There's really been a shift in the last few years for various reasons, but a shift from thinking about seborrheic dermatitis as a malassezia disease, which it does seem to be, to a disease associated with chronic inflammation and complex patterns of inflammation. And I think this study really reminds us that we have a whole lot more to learn about the complex immune dysregulation happening in seborrheic dermatitis. So thank you to these authors for such an important study. And we move on finally to scarring alopecia. 6 studies in scarring alopecia that I look forward to sharing with you, beginning first with lichen planopilaris. Scarring alopecias are a group of conditions whereby the body develops scar tissue in the scalp if left long enough. And that scar tissue in the scalp blocks hair growth and leads to permanent hair loss. And these scarring alopecias go by names like lichen planopilaris, frontal fibrosing alopecia, central centrifugal cicatricial alopecia, folliculitis decalvans, dissecting cellulitis, and others. They're sometimes associated with itching and burning and pain and shedding and redness. And they can cause permanent hair loss. And so patients are really looking for options to stop this as soon as possible to preserve hair. Let's talk a little bit about lichen planopilaris. Lichen planopilaris is a scarring alopecia that, probably occurs in 1 in 1,000, 1 in 2,000 patients. Very much underdiagnosed, underrecognized. It can affect anywhere on the scalp and other parts of the body, but often affects the central scalp. Causes itching and burning and shedding and redness. It's an immune-mediated disease, and so treatments involve corticosteroids, steroid injections, as well as other medications that quiet down the immune system. Immunosuppressants can be used. Other medications that reduce immune activity can be used. And one very clever treatment is an antibiotic called doxycycline. And doxycycline is not a true immunosuppressant, but yet a medication that can quiet down the immune system. So it has a dual role. It's an antibiotic and an immune modulator. In the world, we have high-dose doxycycline, 100 milligram pills. And this tablet has been used for decades for treating all sorts of infectious diseases. The list of bacterial diseases that are treated by doxycycline is an enormously long list. But we also have low doses of doxycycline, 40 milligram pills, 20 milligram pills, 50 milligram pills, that can be used for treating inflammatory diseases like rosacea, for example. For years and years and years, doxycycline had been used at 100 milligram doses, sometimes 100 milligram twice a day. And as these low doses of doxycycline came around to treat rosacea, to treat other dental issues, the question arose, I wonder if these low doses of doxycycline can help LPP, help FFA, help other scarring alopecias. And it soon became clear in the world that, yeah, it does seem to do something. But we've gone for the last maybe 10 years wondering, I wonder if these low doses really are doing anything. Are they better, worse? How do they compare to the high doses? And we haven't really had any good studies to answer that question. Does standard dose doxycycline, 100 milligram, 200 milligrams, compare any better or worse than the lower doses? The advantages of low-dose doxycycline is it's much kinder to our microbiome of our gut. In fact, studies have suggested that low-dose doxycycline, like 40 milligrams doxycycline, really has very little in the way of changes in our gut microbiome. And so if low-dose doxycycline could prove useful in LPP and scarring alopecia, well, that would be wonderful because it affects our microbiome so much less. And so the key point of this study from NYU, New York University, was that low-dose doxycycline seems to work just as well as high-dose doxycycline in controlling inflammation in classic lymphocytic scarring alopecias like LPP, frontal fibrosing alopecia, and CCCA. And what was so much relevant as well was that it was better tolerated. High-dose doxycycline had more side effects, more gastrointestinal upset, and more photosensitivity. So we can achieve good results and good outcomes with low-dose doxycycline without really getting much in the way of inferior results, but yet having a better side effect profile. So a really important study. So tetracycline antibiotics are widely used in the management of scarring alopecia. And when patients first hear that, it's very confusing, isn't it? You're going to use an antibiotic to treat my hair disease? Yes, because these antibiotics can reduce inflammation. They have this dual property. And so the purpose of this study was to compare standard dose doxycycline, 100 and 200, with low-dose doxycycline in adults with scarring alopecia. And so these authors performed a retrospective review of patients seen over a long period of time, 2009, 2023. They had CCCA, LPP, and FFA, 3 scarring alopecias. And patients were in 2 groups. They either got low-dose doxy or high-dose doxy. And most patients were receiving other therapies as well. And they looked at inflammation and scalp symptoms and photos, all the outcomes you can imagine to try to get a sense if this doxycycline low dose is any worse or better or the same as high dose. So they found 241 patients, 82% were female. Current ages was just about 60. 9% of patients were white, 14% were black. Most patients in this study were LPP, some FFA, some CCCA, but mostly LPP. Here's the actual breakdown. 50% LPP, 45% FFA, 15% CCCA. 27% received low-dose doxy, 72% received high-dose doxy. How did they compare? Well, this is the key to this study. There was really no significant difference in the two. That patients on low-dose doxycycline did pretty good. Patients on high-dose doxy did pretty good. There was no difference in inflammation improvement, hair loss stabilization, symptom improvement, or patient-reported outcomes. I think this is a really important study. Side effects were greater in high-dose doxycycline. There was more GI symptoms, more photosensitivity. 1 out of 5 patients stopped the high-dose doxycycline because of side effects, compared to only 10% on the low dose. Really important study that tells us that, low-dose doxycycline has a role in the management of scarring alopecia. In fact, it may even have a role that supersedes high-dose doxycycline. I think more studies are needed, and of course, the ideal would be a randomized controlled trial of the two. But for now, we have these important retrospective studies that really allow us to get a glimpse of the potential answer. High-dose doxycycline is associated with more side effects. And we know it's associated with worse changes in the microbiome. We know that from data in all the good work that's been done in rosacea, that these low-dose doxycycline pills have minimal effects on our gut, whereas the high-dose doxy dramatically change our microbiome. So I think this is a really important study which gives dermatologists the confidence that maybe, just maybe, starting these low-dose doxycycline regimens is not a bad idea. Now, low-dose doxycycline can sometimes be more expensive than high-dose doxycycline and is not always covered by all insurance plans, depending on the person. So that's another additive consideration that we have to think about. But it is kinder to the gastrointestinal tract and associated with less side effects and seems to be just as good. So I thank the authors very much for this important study. I think that this gives us the confidence that, yeah, low-dose doxycycline is quite reasonable in the management of these lymphocytic scarring alopecias. So thank you very much to this NYU group, which does such wonderful work. We turn now to two studies of frontal fibrosing alopecia. Frontal fibrosing alopecia is a type of LPP. Frontal fibrosing alopecia often starts with eyebrow loss, and a year later, 2 years later, 5 years later, there can be loss of hair along the frontal hairline, sometimes at the same time, but it's often a staggered presentation, as well as hair loss on the eyelashes, body hair, underarm hair, pubic hair. And frontal fibrosing alopecia is a scarring alopecia that seems to be increasing in the world. A highly complex immune disorder that's associated with over 40 other immune-mediated diseases. So a very interesting condition that we haven't really figured out in its entirety yet. But I'd like to review two studies this year that really have changed the way we think about FFA. The first study is a very nice study by Dr. Gu and colleagues from Johns Hopkins. The title is Odds of Developing Frontal Fibrosing Alopecia More Closely Tied to Affluence Than Race, a retrospective cohort study. A really, really fascinating study which reminds us that there may be something more to the exposures of patients than the racial background. So let's take a look at this study in depth. The key point of this study that the authors wish to share is that FFA in this study seemed to be much more closely associated with the socioeconomic status, the affluence, than race. And we'll get to that in a minute, but a really fascinating study which shows us that those environmental factors that may be associated with affluence may be highly relevant. And in this particular study, race and racial background did not independently predict risk of developing FFA. Now, FFA is a condition that didn't seem to exist before 1994. Now, certainly one can have endless discussions about whether that's true or not, but the one thing which is clear is it was not very common. But it has risen exponentially in its prevalence. And that has led many to believe that there are environmental factors that are influencing the development of FFA. And those environmental factors were not present on the planet in the 1960s, 50s, 40s, 30s, 20s, but are present now on the planet starting in the 1980s, 90s, 2000 and beyond. And those environmental exposures are responsible for the exponential rise in FFA. And so the race is on to understand what are those exposures. And it's not clear. We go through phases where we feel we're onto something, and then it's still not clear. There have been an interest in understanding sunscreens and moisturizers, as well as the role of allergens. And although the data is fascinating, it's not always consistent, and it's certainly not clear. And so on account of these theories that there's environmental factors which are driving FFA, there's really been an intensive effort to try to understand what could these be. And so these authors from Johns Hopkins really set out to look at the social vulnerability index, which is in many ways a measurement of affluence or wealth to provide some sort of an understanding about how this factors into the risk of developing FFA. And a really fascinating study. Now, the Social Vulnerability Index is an index which is published in the US according to geographic area and zip codes. And the scale ranges from 0 to 1, and a score of 0 in an SVI would indicate areas where there are many people with access to many resources and a higher level of wealth. An SVI, or a Social Vulnerability Index of 1, indicates areas geographically in the US where there's significant poverty, limited access to resources, and very high vulnerability. And so these authors very cleverly looked at the Social Vulnerability Index across various areas and correlated that with the risk of developing FFA, comparing it to also the risk of developing alopecia areata. And so it was a retrospective cohort study looking at patients in their hospital center, and 85% or so of patients were from Maryland. And they linked zip codes to the Social Vulnerability Index and categorized various levels of vulnerability, where a low score was associated with affluence, a high score associated with greater degrees of poverty. And they used multiple multivariate logistic regression analysis to really understand how the SVI factors into the risk of developing FFA. They had 576 patients in their study, 147 with FFA, 429 with alopecia areata. The median age of FFA was 62, and for alopecia areata was 44. And for FFA, 51% were white. For alopecia areata, 32% were white, and 38% were black, and 51% were black for alopecia areata. And here's the key finding. The patients with FFA were more likely from more affluent areas as measured by the SVI. And that was statistically greater in patients with FFA than for alopecia areata. So something very unique about FFA. And more affluent scores, or a lower SVI score, predicted in this multivariate analysis a risk of FFA. Whereas when you factored race into multivariate analyses, it did not come out as an independent predictor for FFA. Just fascinating, which really brings to light the concept that FFA may be more about some of these exposures, and in this case, the exposures related to affluence, than strictly race. And FFA disproportionately affects individuals from more affluent communities. And these authors, really raised the concept that the assumptions about FFA tied to white women may be associated with some overestimation and overstating. And it really sets up a new understanding of what are the exposures in these patients that are contributing to this. It's really a brilliant study that really, drives us to think more about the exposures of patients with FFA. Doing it here by looking at SVI codes. I really like this study. And there have been studies years ago that tried to examine affluence and the risk of FFA. Those studies appeared about 15 years ago and then disappeared. This was a study by McDonald, Clark, and Holmes in 2012, published in the Journal of the American Academy of Dermatology. And in that study, they used an affluence scale called the Carstairs and Morris Index, which is a score not from 0 to 1, like the SVI, but a score of 1 to 7, with 1 being affluent, 7 being less affluent. And what they found in that 2012 study is that indeed, patients with FFA were much more likely to have lower scores. In other words, a greater degree of wealth compared to other patients with skin diseases presenting to clinic. So I think this is a really important study because it really shifts our attention away from, focusing on race exclusively and thinking more about some of these exposures and what are some of the factors. And I remember when I shared that study, the McDonald Holmes study from 2012 with some patients years ago. I had it for many years. I had a number of patients with FFA that were hypothesizing, what could be the reasons? What could be the exposures? Is it travel? Is it that higher affluence is associated with greater travel? And of course, now we have, is it associated with greater exposure to certain products? The answer is we don't know. But I think it's a really important study which, triggers us all to think more about what are some of those factors? What are some of those factors that women and men in areas of greater affluence may be exposed to that patients in lower affluence are not? And the answer is we don't know yet. But FFA is really, the race is on. The race is on to understand FFA and some of these factors. And this is a very important study which really adds to our understanding of how affluence factors into some of the risks. So I thank the authors very much for this really brilliant study. We turn now to one more study in FFA before we leave FFA, and this is the first randomized controlled trial of a topical JAK inhibitor in FFA, published in the Journal of Investigative Dermatology. Here, a brand new JAK inhibitor, which just came to market in North America, although had been in Europe for some time, and that's delgocitinib. Delgocitinib is a JAK inhibitor which blocks many of the Janus kinase enzymes, and it's called a pan-JAK because it does such a good job blocking all these JAKs. The key point of this study is that topical delgocitinib in this small study of FFA was able to reduce inflammation and some inflammatory signatures, and it was well tolerated, reduced inflammation as measured by the FFA severity scale, and actually grew back some hair. And so it was a small study of 15 patients receiving delgocitinib and 15 patients receiving placebo, but really set the stage for what constitutes a well-designed study. These lymphocytic scarring alopecias, whether FFA or LPP or CCCA, are very similar because they have inflammation hiding just under the skin at the level of the isthmus. That's an area of the hair follicle just 2 millimeters under the skin. The reason that's so important is that topical creams have the potential to be able to dissolve into the skin and chase away that inflammation. When inflammation is much deeper in the skin, it's harder to treat it with creams and lotions and gels. But the theory has always been in these scarring alopecias that it's set up for topicals to work well because the inflammation is hiding just under the skin. And so this study looked at how well topical delgocitinib works in FFA. One of the reasons delgocitinib was chosen is that over the last few years, a number of studies have shown that the JAK-STAT pathway is very relevant in FFA. Some studies dating back just a few years by Dubin and colleagues showed that, the JAK pathway is highly relevant in FFA. And so using JAK inhibitors to squash the activation of the JAK pathway is very reasonable as an approach to treating FFA. And so this study set out to look at the use of delgocitinib in treating FFA. And so it was a phase 2 randomized double-blind controlled trial, which is something we don't have all that many of in our well-designed scarring alopecia trials. It examined 15 patients with receiving delgocitinib, 2%, and 15 patients receiving placebo, vehicle. And they received it for 12 weeks, and then after 12 weeks, everyone was shifted to delgocitinib. They took biopsies to look at changes in transcription levels of these cytokines and chemokines, and they measured the FFA severity index, the LPP activity index, and measured the distance between the glabella and the hairline. And they also analyzed safety. Did anybody get any concerning side effects with topical delgocitinib? So there was 30 patients, all female, 15 receiving delgocitinib, 15 receiving the vehicle alone. The mean age was 64 years. Most patients were white. And the baseline characteristics were similar between the two groups. When they looked at their punch biopsies with the transcriptional analyses, they found that this inflammatory cytokine CXCL9, which seems to be highly relevant as an important Th1 cytokine in FFA, was reduced in patients being treated with delgocitinib. Others, like CXCL10 and interferon, were showing a trend to decrease. And overall, by treating patients' scalps with delgocitinib, there was a shift closer to normal and what the non-lesional scalp looked like. And in patients that got vehicle alone, there was a worsening of the inflammatory milieu over time. The FFA severity scale, which was an important marker they used to evaluate the severity, improved with patients receiving delgocitinib, much higher than the placebo. And that is really an important part of this study, that the FFA severity scale was shifted in the right direction compared to vehicle. Topical delgocitinib grew hair in all patients. So everyone had some slight improvement in hair growth with the delgocitinib, and that was really an important component of the study. And so there was reduced recession and actually an improvement in hair with the use of this topical JAK inhibitor. Topical JAK inhibitors in this study were well tolerated. There were no severe side effects that were observed, which is really important. There have been other retrospective studies, some of which we reviewed last year in the top 20 of 2024, looking at topical tofacitinib and topical ruxolitinib. There's always a possibility with these topical JAKs, theoretically, of side effects like herpes zoster. And so more studies are needed with bigger patients over longer periods of time, but it certainly is encouraging in this particular study of 15 patients that there were no concerning side effects. And I think that's really important. So this is the first of its kind, this well-done randomized placebo-controlled trial of a topical JAK inhibitor in FFA, showing that it not only improved clinical parameters, but it improved some of the molecular parameters as well. And I think this really sets the stage for other bigger studies that will be done in FFA and really set the stage for what good studies look like in scarring alopecia. And these are important because we are counting the days until we do get a first FDA-approved treatment for some scarring alopecia. And I think that these types of randomized controlled trials are, of course, the exact trial protocol that will be needed for FDA approval. And I think this all gives us the confidence that, the days are coming when we will have some sort of medication approved for scarring alopecia. And so I thank the authors for this really well-conducted study. The first randomized controlled trial of a topical JAK in FFA. We turn now to CCCA. another very nice study by Dr. Agu. CCCA is a scarring alopecia that affects Black women. And depending on the study, it may affect 6 to even 15% of Black women in the US. And so it is one of the more common hair loss conditions in Black women, and certainly one of the common scarring alopecias in Black women. This was a very nice study which really looked at insulin resistance in women with CCCA. There has been some theories. It has not been supported by all studies, but there has been some studies which have suggested that women with CCCA are at increased risk of metabolic dysfunction, insulin resistance, and the theory that that insulin resistance drives fibrosis. And that, of course, is the reason why treatments like topical metformin, oral metformin, pioglitazone have been studied in scarring alopecia, particularly CCCA. And so as we see patients with CCCA, it's important to be thinking about the concept of insulin resistance. And if there is insulin resistance, really thinking about treating it aggressively, because that may have a role in reducing the fibrosis. The key point of this study is that looking at insulin resistance by measuring glucose and measuring hemoglobin A1C might not be the best way, but rather measuring the HOMA-IR score may be the measurement that we all want to be doing if we're really trying to understand whether our patients have insulin resistance. And that by using hemoglobin A1C alone, we might miss patients that are insulin resistant. And so we have a number of clinical tests to give us a sense of insulin resistance. We have fasting glucose, we have hemoglobin A1C, oral glucose tolerance test, fasting insulins, and the HOMA-IR. And insulin resistance is defined when your HOMA-IR is above 2 and when your hemoglobin A1C is above 5.7. And insulin resistance is a stage which may exist prior to diabetes. Now, this is how we calculate the HOMA-IR, which is short for the Homeostatic Model Assessment of Insulin Resistance, HOMA-IR. If you have SI units, like in Canada, we multiply glucose by insulin divided by 22.5. If you're using US units, which is milligrams per mil for glucose, milligrams per deciliter, you take glucose multiplied by insulin and divide by 405. And you'll get a score. If that score is above 2, your patient has insulin resistance. And so the concept of insulin resistance has, been actively studied in CCCA. And some studies suggesting that women with CCCA have an increased risk of insulin resistance and diabetes. Some studies suggesting not. So it remains controversial. But nevertheless, a large number of well-conducted studies suggesting that there is this metabolic dysfunction. And hemoglobin A1C is commonly used as a screening measure for insulin resistance. And what these authors remind us is that sometimes in the early stages of insulin resistance, especially in young patients, people can pump out a lot of insulin very, very adequately to bring down the glucose, to bring down the hemoglobin A1C. And so they can maintain normal hemoglobin A1C levels, even though they're insulin resistant. And so the authors really wanted to better understand how hemoglobin A1C and the HOMA-IR score factor into helping patients with CCCA. So the purpose of this study was to determine whether the HOMA-IR score is better than hemoglobin A1C in assessing for insulin resistance in patients with CCCA. So they looked at 313 patients with CCCA treated at their center, and 55 of those patients had dual testing with glucose and insulin so that they could calculate the HOMA-IR score, and they compared it to hemoglobin A1C. So these were patients with CCCA. Patients in here were largely female and Black. 76% of patients that had that multiple blood tests drawn, 76% of those patients had insulin resistance. And what this study showed is that the HOMA-IR score detected insulin resistance in 90% of those patients, whereas hemoglobin A1C was helpful in only 55%. And so the key here is that calculating the HOMA-IR score seems to be the superior way of really assessing insulin resistance in patients with CCCA. And so the HOMA-IR score outperformed hemoglobin A1C. And that if you're just using hemoglobin A1C alone, you're underdiagnosing metabolic dysfunction. You're underdiagnosing patients with insulin resistance. You're underdiagnosing patients which potentially have a pathway driven by insulin resistance contributing to fibrosis, and perhaps patients that may benefit from treatments like topical or oral metformin. And so this study really supports that in women with CCCA, measuring hemoglobin A1C, fasting insulin, fasting glucose are all really very much part of the workup and evaluation for patients. And so I thank these authors for such an important study, which really reminds us of the type of thinking that we need to be doing when we meet with patients. And getting these tests out of the way initially are, really so important before other medications are started. So really, really important study, and I thank the authors for this study of insulin resistance. 2 more studies, and then we'll open up the floor for questions. An important study from Spain taught us how successful is hair transplantation in folliculitis decalvans. Folliculitis decalvans is a neutrophilic scarring alopecia which can affect men and women, but often affects the crown or back of the scalp, as you see in these pictures. Folliculitis decalvans can be quite itchy and burning and painful, associated with pustules in the scalp often, and a significant amount of scarring in some patients. Some patients have a lot of scarring. It can be very difficult to transplant a hair from a good area into an area of folliculitis decalvans because of all that scarring. Some patients with folliculitis decalvans have thick scarring. Folliculitis decalvans is initially treated with antibiotics, topical steroids, steroid injections, sometimes isotretinoin, as well as a whole host of other treatments. Dapsone, biologics. And eventually when folliculitis decalvans becomes quiet, the possibility exists to remove treatments. But the scarring is permanent. And so then patients ask, I'm really glad that my folliculitis decalvans is quiet. I no longer have the burning and pain. I no longer have the pustules and bleeding. But is there anything you can do to restore the density? And that's where hair transplantation comes in. How successful is hair transplantation in patients with quiet folliculitis decalvans? And so this group from Spain set out to answer that question. And this group from Spain has done such wonderful work in so many areas of hair loss, but especially recently in addressing those challenging questions of how well does hair transplantation work in some of these scarring alopecias. And up to now, it really hasn't been well understood how successful hair transplantation is in folliculitis decalvans. And the key point of this study is that, yes, it's possible to do a hair transplant in quiet folliculitis decalvans, but it's not always successful. And there's a chance that the disease will reactivate, that the once quiet folliculitis decalvans will become active again. And so this is challenging. And so if you're going to transplant folliculitis decalvans, you first have to make sure it's quiet. And there's considerable debate in our field about what constitutes quiet. How long does it have to be? And if you're going to transplant folliculitis decalvans, you have to be comfortable monitoring for reactivation. What constitutes reactivation? A little itch here, a little itch there, redness, pustules, shedding, pain, burning. How do we monitor? So up until now, the data has been very limited regarding hair transplant outcomes in folliculitis decalvans. Data is quite limited in hair transplant outcomes in scarring alopecia in general. This group from Spain did some wonderful work a number of years ago looking at hair transplant outcomes in LPP. And here they turn their attention to looking at hair transplant outcomes in folliculitis decalvans. And so they really wanted to understand, how good is it? What are the outcomes in patients with folliculitis decalvans that are quiet? So they did a multi-center retrospective study looking at patients with quiet folliculitis decalvans that had been quiet for at least 6 months. And they did hair transplant either by FUE or strip method. And they looked at how likely it was for the grafts to survive after transplantation, whether or not the patient had a flare in disease, and how happy patients were. So they had 11 patients in this study, 8 males, 3 females. Mean age was 36. They transplanted alopecia plaques on the scalp, which were on average 7 centimeters. It ranged from 5 to 12, but that's important, because some folliculitis decalvans plaques can be, the size of much larger than a grapefruit. And these plaques were between 5 and 12 centimeters. And so these are moderate size. I think that's really important, because there may be some inherent differences in folliculitis decalvans of different size plaques in terms of its amount of fibrosis and its biologic outcomes. And they transplanted on average 1,000 grafts ranging from 600 to 1,800, and all patients had been treated before. Here's the key point of this paper. At 1 year after surgery, about 75% of the grafts on average survived. It ranged from 60 to 90. And after 2 years or more, it dropped. And about 60% of the grafts were surviving. And it ranged between 50 and 80. But there was a decrease in survival of grafts, which we see in LPP. And the survival in general was not quite as good as in LPP. And certainly not as good as in androgenetic alopecia, male balding, and female hair loss, where you expect 95% of the grafts to survive. But about 70% of them survived after 1 year, and this was decreasing. A really important point is that 3 patients had activation, so 25%. 2 had flare-ups early on, and 1 evolved into a persistent lichenoid phenotype. In other words, they have persistent inflammation that will require treatment again. But overall, patients were reasonably satisfied. On a scale of 1 to 10, patients were happy with their decision. So I think this is a really, really important study, because it tells us that not all the grafts are going to survive. And over time, some are going to disappear. We don't have long-term data in this study, so we don't know what happens at 10 years. But we can see that the grafts are dropping off. But yet patients are pleased. And so, this is important. In relatively moderate-sized, smaller plaques of folliculitis decalvans, putting hair into that area can provide important camouflage, can make meaningful differences in patients' life, that they feel this was good. Now, not everyone does. But we need to expect some patients to reactivate their disease, so we have to be ready to treat again. So we have to monitor patients, and we can expect that some of the grafts will die. And long-term follow-up is, of course, needed to understand where does that number go to after 4 years, 5 years, 10 years? Does it drop 60%, 50%, 30%, 20%? So that after 20 years, there's no hairs there. We don't know that. And how should we be treating patients that are transplanted? With studies like this, my feeling more and more is that after a transplant, whether it's LPP or folliculitis decalvans, that, perhaps we should be, maybe we should be treating patients with a low dose of topical steroids once a week, or low dose doxycycline, 40 milligrams twice a week, or hydroxychloroquine once a week, or isotretinoin once a week. We don't know. But it certainly is clear that to see these hairs dying year by year is disheartening for the clinician and the patient. And is there something we can do to stop that? But this is such an important study, and I thank the authors for this study, which really tells us that it's an option for patients with quiet folliculitis decalvans. But what really is so important is the counseling that goes into it. That it may or may not be a huge success. Let's hope it is. You may get a flare. The results you see after 1 year may not be the results you see after 2 years and 5 years. So we have to be ready for that. So you hope for the best, but expect some bumps in the road. And so that type of counseling is so important here. And that type of counseling is really what allows patients to feel this was worth it. This was worth my time, my money, and the effort to go through this. So thank you so much to these authors for these really, really important studies. And finally, a study of dissecting cellulitis. Dissecting cellulitis is a scarring alopecia that affects young patients, particularly, especially males age 18 to 24. It can affect females as well. And patients present with areas of hair loss, which can be quite extensive sometimes, and sometimes have inflammation widespread under the arms in the groin area. And we call that hidradenitis suppurativa. And so this particular study really set out to understand whether patients with dissecting cellulitis have more than just scalp disease. Do they have an increased risk for cardiovascular disease? And the key point of this study is that they showed, these authors from NYU, that patients with dissecting cellulitis seem to be at increased risk for both arterial and venous disease, an increased risk for heart attacks and strokes and venous thromboembolism, blood clots in the venous system. And they leave us with a proposal that, maybe more routine screening for cardiovascular risk factors is important for our patients with dissecting cellulitis. And so this is really an important study for us all to think about. We know that many chronic inflammatory diseases, whether psoriasis or hidradenitis, are associated with systemic inflammation. And as we just saw earlier, we're now coming to see that maybe even seborrheic dermatitis is associated with this more complex inflammation. But really, the systemic inflammation associated with dissecting cellulitis has not been extremely well studied, but it has been studied a bit. This was an important study last year in the Journal of Investigative Dermatology from South Korea by Kim and colleagues, which looked at the risk of cardiovascular disease in many scarring alopecias. And in dissecting cellulitis, what they found in patients from South Korea is that there was no increase in risk of cardiovascular disease, coronary artery disease, or stroke in patients from South Korea. And so here we have these patients from the US looking at a large database, again, a global database, but with a slightly different background than the Kim et al. Study, really trying to understand if the risk of cardiovascular disease is increased in dissecting cellulitis. So they compared patients with dissecting cellulitis to controls, 113,000 patients, and matched them for a variety of parameters in this propensity matching, and looked at the risk of arterial and venous disease, including heart attacks and strokes and blood clots. And what did they find? Well, they found that patients with dissecting cellulitis had an increased risk of blood clots, heart attacks, strokes, heart failure, to a much greater risk than controls. The risk of pulmonary embolism was increased 51%, heart attacks 44%, strokes 37%. It's a really important study that really keeps us thinking more about the potential impact of dissecting cellulitis on cardiovascular disease risk. And I think this is a really important study because the risk of cardiovascular disease and scarring alopecia is incredibly debatable. Every time we have a study that shows LPP is associated with cardiovascular disease, we have a study showing it's not. Every time we have a study showing dissecting cellulitis is not associated with cardiovascular disease, we have a nice study like this showing that it is. So we're in the early days of really understanding the systemic associations with these scarring alopecias, but this is a really important time as we understand more and more about these diseases and design studies which can really address these. And they can be challenging to design as we control for factors and we set up the propensity matching in a proper way. But these are important times as we understand that dissecting cellulitis is probably so much more than a scalp disease. FFA is so much more than a scalp disease. LPP is so much more than a scalp disease. Just like we've learned that seborrheic dermatitis is so much more than a scalp disease. Alopecia areata is so much more than a scalp disease. And androgenetic alopecia is so much more than a scalp disease. And so I thank the authors for this, really important study, which reminds us of the importance of at least thinking about these cardiovascular risk factors in our patients, some of who are quite young, and some of them which, if they are at increased risk for cardiovascular disease, we do know that some patients with dissecting cellulitis have a number of cardiovascular risk factors, including a proportion of patients who smoke and a proportion of patients who have obesity. And are there things that we can do to help these patients reduce and minimize the risk of cardiovascular disease? And so I thank this group from NYU very much. And more studies are needed to understand how the study from the Korean database compares to the study from the TriNetX database that I reviewed now. And that brings us to the top 20 of 2025. I thank you so much for your attention. I thank you so much for joining me today. And we're going to post this on our Donovan Medical YouTube channel. And I thank everyone for your interest in these studies. These are 20 really incredible studies that dramatically change how we think about hair loss, dramatically change the thinking that we do, the counseling that we give patients. And like all good studies, these studies set up more questions that will be addressed by additional studies down the road. But I thank these authors for all of these meticulously done studies, which really have advanced the world of hair loss that much more and hopefully improve the care that we give to patients. So I thank you very much.